Hello, everyone. This is Ayan, my friend and colleague, a registered psychotherapist with a focus in complex trauma, dissociative disorder, and who uses the tool EMDR in his practice. So, Ayan, let's talk trauma. How did you get started in focusing on trauma in your practice?
First, Dr. Thalia, I want to just thank you for inviting me for this episode. And I've known you as a good friend for a while, and I'm glad I can do this, in the capacity of two professionals talking about, mental health. EMDR, so before that, actually what got me started into EMDR is this book called The Body Keeps the Score by Dr. Bessel van der Kolk. So it's like a bestseller if you're into trauma work, or if you're someone who's experiencing trauma, and if you've searched for, like, say, PTSD or something on Amazon, that's one of the bestseller books that come up, and it talks a lot about the way trauma affects the brain, and all the different types of modalities that are available when working with it. And so when I read it back in, I think, 2016, just after I had graduated from a psychotherapy program, I was like, oh, holy shit, this is something very different. It was like kind of mind-blowing, very different. And then a friend of mine introduced me to EMDR training that was happening, and I did the training in 2016, 2017, and yeah, and that's how it started.
That's cool. What about the book drew you in?
So the book really, because the thing is, and this is common for all schools of therapy, when you study therapy, at a school, at a graduate program or something like that, the focus is quite a bit on still that old school psychodynamic approach, or more like that CBT-like approach, right? And this book for the first time introduced me to a more of a, what we call, neurobiological approach, and at least this is my perspective, and might be the perspective of a lot of other trauma therapists, is that the trauma, the way it is stored in our brain, typical just doing talk therapy, just like talking about it, just like exploring it, just insight generation in itself, doesn't do much to dislodge the negative effects of the trauma. I mean, you can then, it's like, I had made an artwork at one point that you can do a PhD on your trauma, and yet the symptoms persist. Like, you can have a lot of insight, what happened, etc., but the symptoms are happening in a different part of your brain. And so that's where I had this realization that, wow, like, whatever I've learned, that is good, but when dealing with this kind of stuff, there has to be a neurobiological aspect where you're trying to bring shifts in that part of your brain, in your more primal parts of your brain, rather than just neocortex, rational.
Yeah, we talk about this, like, that's one of the main criticisms of therapy, is that, oh, I'm just going to end up spending years, circling and circling and circling around this central issue. And I think what you're saying is the part of the brain where trauma lives is not necessarily accessible to the part of the brain that generates narratives and speaks, which is the neocortex.
Yeah.
And so there are these deeper, more animal regions of the brain where those, I think they're called implicit emotions, are stored.
Yeah. And I can, that can be a good segue for me to explain EMDR a little bit, if that makes sense. So EMDR stands for eye movement desensitization and reprocessing. Essentially, it's a form, it's a therapy meant for, it's typically a memory reprocessing technique, but now what has happened is it has been expanded further to, instead of calling it a memory reprocessing technique alone, you can call it as a way to reprocess dysfunctionally stored information. So whether that's memory, whether that's difficult body sensations, whether it's your amygdala getting activated and you're getting like lots of anxiety and that anxiety symptoms, even if it's not related to individual memory where you're like, oh, I'm going back to that memory. It's about reprocessing that dysfunctionally stored information. So what we are essentially trying to do here is we are activating the brain's own adaptive information processing system. So the brain has an adaptive information processing system by which it takes new events, new things that are coming in, and it kind of like strips off, so for example, if you had, lunch somewhere. If you had, now it's quarantine, so you're having it at home. But if you
Ordering
had,
Thai food. Yeah.
yeah, yeah. But yeah, say for example, you ordered Thai food and you're having, lunch on your, say, dinner table. And what's happening is, for your brain, that's giving you information. That's like, oh, this food tastes like this is that. And what it does, the information processing system, is that it's, when it processes that event, it strips off the incoming event. So the incoming event is like an undigested piece of food. Like, it just comes with all its, components all meshed together. And the way the stomach divides everything, carbs, proteins, fats, the brain is kind of doing the same thing. It's like dividing it. This is the visual component. This is the emotional component. This is the taste component, things like that. Makes meaning out of it and then sends it back into long-term memory storage. And long-term, and so that's what is happening. But when trauma happens, what can happen is your brain can go into survival mode. And in survival mode, the brain focuses on certain tasks and deprioritizes certain other tasks. And then this information processing can sometimes get deprioritized, or if the trauma was very intense or happening for a prolonged period of time, this processing might just get stuck. It might just get broken. So then what happens is, this trauma memory doesn't get then broken down into its individual components. Meaning making doesn't happen properly. And this trauma memory is now not sent back into typical long-term memory storage. So what's happening instead is that it's like undigested food running through your system. It's going to cause your system to get upset, right? And what happens is, this memory then gets what we call isolated memory network. So think of it this way, that when you have a memory network that has been well integrated within your system, it's like think of it like a wall of memories and events that make up who you are, right? And isolated memory networks are like, almost like, this is a wall of memories, and you have this one memory sitting outside of that wall of memory, kind of like in a bubble, not connected fully with the rest of the memory system.
Is it because it's an anomaly in our experience, like our brain, or we haven't quite made sense of it yet because it was so traumatic?
Yeah, it's because your brain wasn't able to like integrate that event into the rest of your long-term memory system. How that actually looks like in real life is, if you have, say, a really traumatic event from childhood, and this could even be like, for example, that seems quite minor now, but could be quite impactful back then. So for example, being humiliated in a show and tell at school. You're showing and telling something and kids are laughing at you. Now when you think about it, it may not be that big a deal, but for that fifth grader or fourth grader, that was like life and death up there in front of the kids, right? And so that's when trauma can be that as well. It doesn't always have to be war, rape, sexual abuse, accidents. It can even be, and I can come to that a little bit in a moment. So what's happening then is that childhood memory and what you had for lunch 4 days ago. Childhood memory is a lot older, but it can still feel very vivid. It's as if it's happening right now. Versus what you had for lunch 4 days ago, unless you had food poisoning, you won't really remember that. I will have to kind of jog your memory to be like, okay, what did I have 4 days ago? But a memory that's from like 20 years ago, if it's traumatic, you'll remember it as if it's happening now. And so this is the isolated memory networks and all of that. We're trying to explain as to why is that happening, right? Why is a memory 20 years old? How is that so vivid? And something that's 4 days old, how is that kind of like can't even remember? And so with EMDR, essentially what we are doing is we are kickstarting the brain's information processing system by activating the memory. So it's in that emotional memory center. Oh yeah, and before that, important thing to note is that, so now with this trauma memory sitting there with quite a bit of negative affect, negative emotion in there. And we all have a negativity bias, right? That's a survival bias. So if I say 9 good things about you and 1 negative thing about you, you're going to focus on the negative, right?
Definitely.
Yeah. That's how comment wars get started, right? Now, on social media.
Totally. Yeah.
And so that negativity bias causes the brain to go like, okay, this thing has a lot of negative emotion, which didn't get stripped away, by the way. The emotions didn't get stripped away because it didn't get processed. So this must be really important. We need to pay attention to this memory. And that's why that memory then goes and hangs around in your emotional implicit memory center, which is a different part of your brain as compared to your long-term memory center. And what that looks like is implicit memory center is also the place where you have, it kind of overlaps with procedural memory. So if you know how to ride a bike, throw a ball, a muscle memory of that sort, trauma memories can kind of get lodged in there. And so that's when you can have what we call flashbacks, where this memory now, even though it's really old, it's pretty much sitting on the surface, just below your conscious awareness. It's like kind of right there. And any random trigger can then resurface that memory again and again. And you can get a full flashback where you're seeing the context, where you're seeing the image of the memory and all of that. Or you can get a partial flashback, which is where you're not getting the images and the context, but you're getting the body sensations associated with the memory. So, do you have any questions?
Well, I just wanted, it reminds me that it's very interesting that our traumatic memories are stored almost like we think of, oh, it's just like riding a bike. You haven't ridden a bike in 20 years, but you can get back on one and your body remembers how to do it. Yeah. You don't need to consciously think about how, I'm holding it like this, I'm putting my feet on the pedals like so, you just do it. It's kind of like drops down a window pane. When there's already a track that's ready, the drops follow that track. And so our brain, our traumatic memories behave in the same way, where it's like you don't need to consciously pull up a traumatic memory. Small triggers, just as riding a bike, like getting on the bike triggers the whole process of riding a bike. These other things can trigger the entire traumatic memory to start activating itself and going down that pathway that it remembers.
Exactly. And and what's happening also is that your amygdala, which is your brain's smoke alarm, which decides what's safe and what's dangerous, what ends up happening is for the amygdala to compare, amygdala is nothing but the thing that compares. Like when a new stimulus is coming in, it's going to compare. Have I seen this before? And if I have, is this safe or dangerous? And what does it compare it with? It compares with because it's in the emotional part of your brain, it's in your limbic brain. So it compares with what's in your emotional memory centers. It doesn't compare with what's in your long-term memory center. It compares with, okay, in the emotional memory center, I have this big trauma memory, and this thing that's coming in of someone who's, looking at me weirdly, is activating my, the memory of someone yelling at me, a teacher yelling at me in front of the whole class in grade 5, and now my boss is looking at me weirdly, means that this is about to happen. So you know what, body, get into fight flight, get that anxiety going, because this is about to happen. And so with the EMDR, what we are doing is we are activating the brain's information, kickstarting the brain's information processing system, while activating the parts of the emotional brain that are holding the unprocessed memory. And so we activate those. So typically another thing that happens in so you have your emotional brain here and you have your rational sort of logical neocortex brain, right? When you're doing, say, only like talk therapy, what's happening is your rational brain is activated, but often your emotional brain is not really activated. If you're doing something like just plain old exposure, where you're just exposing someone to something, or you're re-traumatizing someone, you're just going to the story, getting them to feel, is where this is on now, the emotional brain is on, but the rational brain is not fully on. It's like kind of switched off a little bit. So that causes re-traumatization, reliving. But with EMDR, we are trying to switch both of them on at the same time and helping this linkage formation. So like almost like your information processing system, how it looks like in session is now this person is starting to link this isolated memory to other parts of the memory network. And then that memory pretty much gets digested.
Yeah, I was just going to say, it sounds like a digestive enzyme where you have this food sort of sitting there, and now you're helping it become processed and incorporated into the body or into these other memory systems that you're talking about.
Exactly. And What that looks like is when we initially activate the memory, it could be like, so if I use the example of a teacher yelling at you in grade 5 and humiliating you in front of everyone, it could be that how the setup would look like is when you go to the memory, what's the worst part of the memory? Okay, so, or the worst part is seeing the teacher's face looking angrily at me. The second thing that we would ask is when you're looking at the image, what's a negative belief or thought about yourself that's coming up for you? And the negative belief could be like, I'm not good enough, I'm not worthy, I'm stupid, something like that. Then we also look at positive belief to make sure that this person has the adaptive information in there. So we say that when this is all healed, what is a more positive belief that you would like to believe about yourself? And they may say that, I'm smart enough, I'm good enough. That's the positive belief. Then we do a check as to like how strong is this positive belief within this person. So we say from a scale of 1 to 7, where 1 is false and 7 is completely true, how true at the moment when you bring up the memory, how true does this positive belief of I'm good enough or I'm smart enough, how true does that feel from your gut, not rationally, but at an emotional gut level? And the person may say, oh, it feels like a 2, like or 3, like I can't really believe in it. It feels like a lie to me. And then we do feelings. So we check, okay, now when you're going back to the image of the teacher's face, notice what feelings are coming up for you now. And we are eliciting feelings now rather than what came back then. So the person may say, oh, I'm feeling anxiety, anxiety is coming up, okay. Then we do a subjective unit of distress. So we ask them from a scale of 0 to 10, how distressing or activating does this feel? They may say, I feel like a 7 or 8. And last we do is, where do you notice this in your body? Where is the activation the most? They're like, oh, it feels like in my chest or in my solar plexus. That's it. Then after that, what we do is we do bilateral stimulation. So bilateral stimulation is another EMDR thing where we are trying to do like either a left brain, right brain thing. So this could be eye movements where you're doing eye movements left, right, with a pointer or with your fingers, or you're doing like taps. So you can do butterfly taps like this, like, on your arms, or you have these buzzers. So like these vibrating devices that you hold in your hands and they tap alternately, or you can do audio, that's bilateral, so alternating. That what it does is left brain, right brain thing on one side. And secondly, it creates something called dual attention awareness, which is that your brain is now aware or working on on the emotional brain, like on the emotional memory, and at the same time is doing this thing of tapping or following the eye movement. So the brain is having to maintain dual attention. And that seems to be key in doing this reprocessing thing. And so we keep doing sets of this, maybe about, say, 30 seconds to 20, 30 passes, and we keep doing sets of this. And as we do it, we're asking, after each set, we're asking the client, okay, what comes up for you now? And it could be completely unrelated. I have had clients go like, oh, I'm thinking of a beach now, or I'm thinking of this, thinking of that. And what we do then as therapists is, as much as possible, to stay out of the process, to keep ourselves there relationally, but stay out and let the brain do the heavy lifting. So as a therapist, all I'm doing most of the time is, okay, notice that and go with that, and next set of eye movements or tapping. And I'm not doing any interpretation. I'm not doing any, so this is what this means, or questioning, nothing. You just let the brain do its thing. And now and then I would come in there to do any interventions. We call it cognitive interweaves or interweaves in general. If the process gets stuck. So if the person is what we call looping. So looping is, so 2 to 3 times the person is say they're like, oh, I'm seeing this memory and it just feels hopeless. It just feels hopeless, right? And we do 2 sets and I see that this keeps saying that this feels hopeless. It's not moving. Then we may do an interview, and we want to keep the interview very short, very precise, almost like a um, it's like a laser focused interview. So I may say something like, if this was happening to your own child, that they were going through this, what would you like to say to them? They may say that, oh, if this was happening to my own child, I would say that it's okay, this too shall pass, it's not that bad. Like, okay, notice that, go with that.
So you're
And so
sort
we
of
have brought,
just bringing a reframe almost.
exactly,
Mm-hmm.
and we bring in that adaptive information, reframe, and get them out of that stuck situation. At the end of it, then we ask them, now when you go back to the memory, 0 to 10, how activating does it feel? And they may say, oh, it feels like a 1 or a 0. And 0 here means that the 0, suds of 0, subjective unit of distress of 0, means that this memory is now neutral. So which means that it doesn't mean that now it's a happy memory or a good memory. It just means that, yeah, it's something bad that happened to me. But now when I think about it, I don't get that activation. I don't that anxiety or whatever that I was feeling. It's my EMDR trainer used to call it, it's turned into Sunday's blueberry pancakes,
Mm.
right? Like
It,
that.
it,
It's just like
mm,
what I ate on Sunday, right? It doesn't really
mm.
activate me anymore.
Like
And
it's
one,
something that just occurred in the past and has no real meaning about the present and your identity. Sounds,
exactly.
yeah.
And then we do the installation phase where we then go like, okay, now when you bring up that memory, now when you bring up your positive belief, what we call the positive cognition of I am good enough or I'm smart enough, how true does that feel from your gut now? 1 to 7, 1 is false, 7 is true. And you would notice typically that that increases. They may say, oh, it feels like a 6 now, I believe in it more. And then we do further more sets to make it go all the way up to a 7, which is true. And we'll see, and we'll, if it stays at a 6, means that there might be some other memories, that there might be something else that's blocking that process. Okay.
Mm.
So this is what a typical EMDR session may look like. And you can have, so what I mentioned was a full completion, like a full, what we call a completed processing set. And you can also have partial incomplete sets where, because we are running out of time, or there are other blocking beliefs and feeder memories and things like that, the client might only go down from a 0 to 10 to like a 3 or a 4, and we might have to end the session there. We do so by containment. We contain the client, container, calm place. We ask them to imagine that they're at a calm place, safe space. And these are things that we have already practiced before in the preparation phase. And then we kind of zip up the client, and then they can end the
Mm.
session.
You like close up those memories. And so a few things are happening. You're in some ways reactivating that implicit memory, like you're reactivating the amygdala, encouraging the person to really be in the memory where they feel the emotions, they feel
Yeah.
the beliefs, they're back in grade 4
Yeah.
in front of the class being humiliated,
Yeah.
and also calling up what they made that mean, or because the memory's unprocessed, so there's still somehow it's been woven into an identity system and a belief system about themselves that is
Yeah.
polluting or bogging down a more positive belief. And the more positive belief doesn't sound like it's like, oh, I'm the smartest person on earth. It's a more balanced belief. If I am smart enough to ... or even just smart enough in general.
Yeah.
But you have this memory that's somehow polluting that ability to clearly see reality. So you're sort of just, again, digesting that memory up so that they can see life clearly. It's like, oh, this thing happened to me in grade 4. It was not great, but it no longer
Yeah.
pollutes my present and future.
Exactly. Exactly. Yeah, and as you said, present and future. So EMDR is also a three-pronged process. So what we mentioned up till now is the past. So we do the past memories. Then we do current day triggers. So current day triggers would be that, okay, now so once the past memory has been, desensitized and processed, then we look at current day triggers to be like, okay, so what you came in for, what did you come in for? You came in that I freeze up in presentation. So when I'm presenting something at work, I freeze up. Okay, so that's because people don't typically come and say, oh, typically, unless there's PTSD, significant PTSD or complex PTSD, typically the client doesn't say, oh, my grade 4 memory is getting activated. Can you please do something about it? They don't say that. They're coming in saying that, okay, I'm freezing up. I can't, when I'm supposed to give a presentation, even though I'm really well prepared for it, I just can't speak. I'm getting tons of anxiety. That's what someone is coming in for, right? And so the grade 4 memory that we worked on earlier would be something where we do a float back process. So float back would be like, bring up the current thing. So you freezing up in the session. Now, when you look back into the past, you let your mind go back into the past. When have you felt this for the first time, or when going back to a memory when you felt this really intensely? That's when the grade 4 memory gets activated. That's when it becomes, they're like, oh, this reminds me of that time in grade 4. And so once we process the grade 4 memory, then we process the current day triggers. So we are like, okay, now you You imagine your boss's face or you sitting in a, you know,
Mm.
meeting room about to present. What do you get? How what comes up in your body? And then we do the same process to digest that. And then we do something called a future template, where you're now imagining that you're going to present next week, what comes up, and if there is any, dysfunctionally stored information, any negative affect, any negative emotions coming up, or body sensations, we do the same. We clean it up. Yeah, and so past, present, future.
Mm. This is really cool. And can you speak more about the motor and sensory activation of touching the body or the eye movements? Like, it reminds me a little bit of REM sleep, and how that's often the time when our certain memories like that can actually be processed by the brain.
Yeah. So at the moment, what has happened is, even though EMDR has been, it was something that was discovered by a psychologist named Dr. Francine Shapiro. Um, like, even though it's been in the public domain since about 1988, 89, I think. We still don't quite know what's exactly the reason why the processing happens. So there are a bunch of theories. One of the theories is REM sleep, right? Like, eye movements. But then we've had similar results with like taps and like
Mm.
tapping and things like that. There is another theory around what's happening is you are activating, it's called, I forget, the term is called expectation error. Expectation error is like your brain, you're activating, say, an anxious memory, and your brain is sort of expecting something negative or expecting something activating to happen. But then tapping and the eye movements typically are a calming response. So you're giving the brain an expectation error that, oh, I'm expecting something bad to happen, but I'm getting a calming response. And
Mm.
so then the brain has to kind of resolve that. On one side, this should give me a negative experience, but I'm getting a positive experience. So let me revise that. It has to resolve this disconnect. Then there's something called the theory called the working memory theory. Working memory theory is that's the new coming out of Europe called EMDR 2.0, and it's a new thing that's coming in. Working memory theory is that we are pulling up the memory, the negative memory from coming in, and then we want to load or make that working memory part of our brain work hard,
Mm.
like really loading the working memory part of the brain, and keeping keeping the emotional negative trauma memory within your mind's eye, within that working memory, and you're loading the working memory, and that somehow seems to digest the thing. And loading working memory can be in the form of, I'm using this technique now a little bit, still a bit controversial, but what you can do is you activate the memory, and then instead of doing regular eye movements, you're doing random eye movements. You're removing the predictability, so your brain now has to like figure it out. While the set is happening, I'm asking them to tap. While that's happening, I'm asking them to spell words backwards or do basic math like 5 plus 10, 13 plus 17. And so it just activates, it loads their working memory. And somehow then when I ask them, okay, now when you go back to the image, what comes up, they're like, oh, I can't even remember the image,
Mm.
right? So that's the new development that's coming from EMDR. So there are lots of, to answer your question, lots of different theories right now. We still don't know exactly what helps.
It seems like I mean, you're trying to keep the prefrontal cortex activated
Yeah,
by engaging the brain in some way,
yeah,
whether, and so like motor, I mean, activating the motor centers, um,
yeah.
is probably one of those ways in which you're keeping that person present, because you can
Present.
only act in the present.
Yeah,
Whereas the memory is going to maybe convince you that you're acting or need to act, but
yeah,
it's irrelevant. The actions are based on a memory that happened 20 years ago, are likely irrelevant to the present, which is
yeah,
the whole idea of trauma. Is you don't necessarily need to be in a fight or flight state
yeah,
remembering a humiliation that occurred a couple decades ago, because there's no response required. The situation is not currently happening.
yeah.
And so
Yeah.
it's almost like teaching the brain that it's like, all you need to actually be doing right now is moving your eyes or tapping or doing math while we sort out
Yeah.
this 2-decade old memory.
Yeah, exactly. And I just want to mention to your audience, as well as the last bit that I mentioned about EMDR 2.0, that is not standard EMDR protocol yet. So what I explained earlier in the steps, that's standard EMDR protocol. But what I explained just now, last few minutes, that's not standard. So I just, yeah, because I'm a certified EMDR therapist and a EMDR consultant in training, so I need to kind of toe the EMDR line, so to let you all know that what is standard and what is not standard.
Right. So if your therapist is getting you to do math in a session,
Yeah.
look
No,
alive. It's probably not normal.
yeah, if it works, great, but just know that that's not standard EMDR at the moment.
Mm-hmm. Right. And it's sometimes important to, like, there might be a reason why you would stray or stray from the treatment fidelity and do the math problem version, but likely, you probably will start with eye movement and the standard protocol first.
Yeah. And in EMDR, in the EMDR world, there are a lot of different, what we call different protocols. So you have the standard protocol, and then you have all these different, protocols for this, protocols for that, protocols for addiction, protocols for like lots of different protocols. But the thing is, as I'm trying to become a consultant now in EMDR, so I would be helping other EMDR therapists get their certification hours and things like that. And so there, one thing that we kind of want to drill in is that okay, using different protocols is great, but you need to know why you are breaking fidelity from standard protocol. Like if you're using this new thing, what is the reasoning? Do you have a solid reasoning as to why you're doing so? And if you do, and if the protocol works, then great. But just to do random things without knowing why you're doing it or why you're skipping a particular step. Because another thing that I want to mention is the risks of EMDR. EMDR can, in the hands of someone who's not well trained, or there are actually certain programs, certain things that are not accredited by the EMDR International Association, is like doing EMDR by yourself. Like, oh, it's just eye movement. Just watch this video of someone wagging their fingers, follow that, and your trauma is gone. The problem with that is that because we are activating old memories, for someone who has these memories kind of tucked away and locked away and dissociated away, bringing up the memories like this can cause something called flooding. Flooding is where it's not just one memory now that's coming in. Now all these memories you have a bunch of different negative memories. They just flood you in, and it can cause significant destabilization. It can even lead to higher suicidal ideation. Um, just like high anxiety, high depression, like whatever is happening can destabilize you significantly. And so that's also a risk of, even when you're doing standard protocol, even with a sort of a certified EMDR therapist or a professional, that's a risk that we are working with, right? And we are doing all these preparation, working on dissociation, all that kind of stuff as a way to minimize that risk. So EMDR there is that inherent risk to it.
Like we've talked about that before, because and this is maybe a good time to talk about this, is some people, some of my patients have tried EMDR, and they know, let's say they suffer from anxiety, maybe generalized anxiety disorder or specific phobias, and they're able to pinpoint that to maybe a series of memories or specific isolated trauma in the past. And they're like, well, I've done EMDR and I just feel sleepy. But I think what we want to talk about as well is this, dissociation is one of the ways that we protect ourselves from all of those memories that we may not be able to consolidate in the present, and that EMDR facilitates that process. But it's the idea of opening the can of worms. If we don't really know what's in there, and the patient or client is protecting themselves from those memories and those experiences. So how do you work with that when someone is either dissociating or is experiencing a very anxious state and is hyper aroused? Let's talk about that.
Okay, great question. So dissociation, I want to say that dissociation typically when you train to become a therapist, dissociation unfortunately is one of those things that is, no one really talks about it in therapy schools. It's like the level of exposure that it gets where ideally it should get a ton of exposure, but the level of exposure it gets in therapy schools and often in bigger mental health institution is very minimal. Like, it's just, people think of dissociation. So dissociation, another thing is, as you mentioned correctly, that it's a defense mechanism. We can look at dissociation in two ways. One is physiological dissociation and one is structural dissociation. So physiological dissociation is typically when people think of dissociation, that's what they are thinking of typically, is say, for example, this person has just had a really bad accident. And in the accident, they're really badly hurt, but they're not feeling any pain. They are like they're looking around, not feeling any pain. They're lucid to some extent, and almost feeling like the ambulance coming in, the fire truck coming in, the cop cars roaming around. They're looking at it as if it's not happening to them. It's like this, it's like this movie playing out, and I'm just there. It feels very surreal. Those are all signs of dissociation. We can call it derealization, depersonalization, and physiological dissociation where you're not feeling any pain and things like that. Typically what happens is once the event is over, within a few hours or a few days, that kind of dissociation generally wears off, goes away. So that's physiological dissociation. And sometimes what can happen is, and I feel that um, in more traditional mental health institutions, dissociation has been looked at in that way, that, oh, it's just something that happened to you when you were traumatized, but now it's, then it went away, it's gone, right? But what can happen is physiological dissociation can persist. One, that it can give you depersonalization, derealization, even a year after the accident was done, you're still feeling kind of like derealized. You're feeling like everything is still a movie, or you're feeling kind of like out of body a little bit. So we can work on that as well. And typically, to work with that, you need other modalities. EMDR can be helpful, but EMDR typically, how we would with EMDR, we would actually do the reprocessing of the original memory, and that way the physiological dissociation kind of starts to wear off. And then there's something called structural dissociation. Structural dissociation is now what creates dissociative defense mechanisms internally for people. And this is often seen with childhood trauma. This is often seen with childhood trauma. So structural dissociation, I'll give you an example. So imagine, there's this child who's, say, like a 6-year-old child. This child now she gets, like, say, abused by her dad, like, say, beaten by her dad. And now she's like crying and all upset and like just like big emotions and all of that. And this is, 9 p.m. on Sunday night, right? And now Monday morning is coming and she needs to go to school. In school, she's a popular child. She has a lot of friends and she has an image to keep up with, right? And she cannot go into that school setting with all those, the negative feelings and the big emotions and the tears from last night, right? So there starts to happen this fragmentation where that crying 6-year-old child has to now be kind of like pushed away and locked behind this door so that her popular girl persona can come up, and for her to be like as if nothing happened. Things are great, things are fine. She's going through her emotions, doing what she needs to do from her daily living thing. So we look at it as, this is called structural dissociation, where you have the daily living system, which is her operating in that school, and then you have the defense system, which is the fight, flight, freeze, fawn mechanisms that got activated with the trauma. Over time, what happens is, if this keeps happening all the time, there seems to be this dissociation that happens where um, there's so much gap now that comes in between this daily living system and the defense system, is that to the daily living system, it could even be that defense stuff, that crying 6-year-old is not me. That's not me. That's someone else. That's some other girl. That's not me, right? And if this happens in an extreme way, that's when you start having dissociative identity disorder or multiple personality disorder. The new name for it is DID. That's an extreme version of this fragmentation that's happening, right? And so how does that look in session? In session, what it can look like is, you can have a client, for example, who comes into session saying, oh, I've done a lot of personal growth work. I want to do this. I have a bunch of traumas, but I want to work on this, and all of that. And if you ask them to, tell you about the trauma, two things can happen. Either they have complete amnesia, they don't remember the stuff. They'll be like, oh, I had a decent childhood, nothing bad happened. Or they can narrate the trauma like perfectly. They're like, oh yeah, my dad sexually abused me when I was 6 years old or something, and yeah, I can tell you about the trauma. What do you want to know, right? And what's then, so someone who has worked with dissociation, I'm looking at it that, oh, okay, so it looks like the person who is talking to me right now is that daily living system, is that kind of like, in structural dissociation term, we call it the apparently normal part. So the ANP is showing up, and the ANP wants to talk about the trauma, but the ANP feels that the trauma didn't happen to her, that it happened to this whatever, some other 6-year-old child part, and I have a lot of the apparently normal part can have a lot of negative feelings towards that child part. It could be like a lot of fear that I don't want to deal with that child part because when she comes up, I get destabilized, I feel all depressed. I don't want to deal with her because she keeps crying, she keeps hijacking, she's clingy. So the adult can have, and this is what we call dissociative phobia. Dissociative phobia is basically this inner defense that's preventing the daily living system from, accepting and realizing the child parts or the emotional parts who are holding difficult memories and feelings.
It's fascinating. Yeah.
Yeah.
Mm.
And so what we are then doing is, before we can do memory work, because we can't quite do memory work here, because what's going to happen is, in this situation, what's going to happen for EMDR therapist who doesn't have, dissociation training, which is happening more and more now with EMDR trainings these days. Most EMDR trainers are bringing in more awareness for dissociation. What will happen is, if a client comes in like that, you're like, oh, this client seems ready to do processing. So let's go to the childhood trauma memory, the sexual abuse or physical abuse memory, and we try to do EMDR. What might happen is, in the session, the client may not have much activation. They'll be like, oh, when I go to that memory, it's a 3 or 4 out of 10. It doesn't feel too much. And you're like, oh, okay. And you do the sets and it comes down to a 0 or a 1. And you're like, oh, wow, look at that. We did the memory. And then the client cancels for the next session, or you learn that 2 days later or a day later they were completely flat, they got super depressed or high suicidal ideation, and you as a therapist, you're like, oh, but I thought everything went well, like what happened here, right? What ended up happening is that activation, that going to that memory, now activated the child part, who was holding all the negative feelings and emotions, and that part got significantly activated. And then that part, because it got activated so much, that part then came and hijacked the adult part, or the apparently normal part. And so when a hijack happens, what happens is your rational thinking ability, your adult self in a way, gets kind of kicked to the curb. You are now losing all your skill sets, all your adult way of thinking, the rational thinking. You're now being hijacked by a 5-year-old, 6-year-old, 10-year-old. And that, for that child part, the trauma is happening now. It didn't stop. You're no longer 30 years old. You're still 6 years old. And the trauma is happening now. And so it can feel really hopeless. It can feel really traumatizing. And now this person is having suicidal ideation.
So it's like that person is trying to go about their daily work. They're in their sort of popular, apparently normal persona. And then all of a sudden they're being hijacked by a 6-year-old. So maybe spells of crying or severe panic or irritability or rage. Or I've seen cases where patients would talk in accents, different accents, or in languages that they spoke in early years of their lives that they no longer speak.
For sure. I have a sort of a DID client right now, and we always start the session with her ask like, who am I speaking to right now? Right? And whenever she has been in her like 13-year-old, 12-year-old, she speaks more like, kind of like, I am speaking to you right now, like almost like a childlike way of speaking. And the moment I ask her sort of adult self to come in, she sits up a bit more and she starts talking like a woman in her early 20s, versus like in that more childlike way. And so this is something that we need to work on. This is something that we need to address. And typically we use something called structural dissociation theory as a way to where we do parts work, where we now go like, okay, this part of you, who is, let's bring up that 6-year-old then. And we use certain techniques to basically heal the dissociative phobia between the adult part or the apparently normal part with that emotional part. And so we want the adult to be able to be looking at this child part with more compassionate eyes, with more loving eyes, be able to take care of the child part, be able to integrate that child part with herself. And that's how the dissociative barrier starts to dissolve, because dissociative phobia is nothing but a barrier. It's like a wall. It's like a wall between the adult and the child part. And the wall is there to prevent the child part from taking over the adult and for the adult to be able to do whatever it needs to do. And if we blast the wall, if we just demolish the wall, then the adult hasn't developed any additional capacity to deal with what that child part is going to bring now. And it's going to flatten the adult and cause a hijack. What we do is we you know develop the adult's capacity for compassion, self. This is where we're developing adult's capacity for self-compassion, self-love, good self-care, those kind of things. And being able to tolerate and even over time like and love that child part. And so when that starts to happen, that wall starts to get kind of you are basically uninstalling the wall brick by brick. We're bringing it down slowly. And so afterwards, then the wall doesn't need to be there. And then we can do memory work. Then we can go into the childhood memory because then we know that the client is getting fully activated to the level that the memory should bring activation. And we know that after the session, the adult self will be able to calm and reassure that child part and still be able to be in their adult self and not get hijacked.
How would one recognize, like you were saying, sometimes it can show up where it looks like a great session from the outset. It looks like, the person's sort of activated by this memory, but it's sort of a 3 or a 4 out of 7.
Yeah.
And then at the end of the session, they're awesome. It looks like you've cured them basically. But then between session, you're seeing this activation. Are there any warning signs beforehand? Like, should somebody considering EMDR, are there certain things that they might need to talk to their therapist about before they decide?
Of course, yeah, and that's a great question again. So now what's happening is with EMDR training, all EMDR training, now they're bringing in this thing called the DES inventory. So DES stands for Dissociative Experience Score or Scale. It's basically a list of, I think, 28 or 26, 28 questions, which are typical, and you're basically scoring them from 0 to 10, 0 to 10 being the frequency, like how often does that happen to you. And an elevated DES score can tell you that this person has some dissociative process going on, so to be careful and work on the dissociation. And it has questions such as typically what we look at as memory loss, so something like it's 1 p.m. and now suddenly you see it's 4 p.m. and you don't remember what you did in the last 3 hours, or you are now at a place and you don't remember how you came there, or you feel like what we call intrusive thoughts, feelings, or what we call made thought feelings, where you're suddenly like hearing a child cry within your head, or you are having just a thought of like suicidal thought just intrude, like you're just watching TV and suddenly there's thoughts coming in, what we call intrusive thoughts coming in, saying this, saying that, or saying something negative to you. So this thing, 28 questions, it lists out these questions, and you ask the client to rank as to like 0 to 10, how often does it happen to them, and based on that we can figure that out. For someone who works with more dissociative, like one of my things that I'm specializing in is dissociative disorder, I use something called the MID, which is the multidimensional inventory for dissociation. That's a much longer, it's like about 200 something questions, just one-liners of experiences, and you again rank 0 to 10, because DES can give you false negatives. So someone can have a low DES score and still have dissociation, while the MID is a bit more accurate, and it tells you what kind of does this person have self-harming voices? Does this person have child parts? Does this person have, like, it kind of breaks it down and can be, so that is something that I use with not all my clients, but with, in my intake, I would typically ask them, do you have some of these? I'll ask them a few of these questions. If I hear even a yes for one of them, then I would ask them to do the MID. If it's not, if it's like just, what we call garden variety PTSD, then we're like, okay, we don't need to do MID.
That's great. Yeah. So it's like you're really increasing the sensitivity of these kind of questionnaires just to make sure that nobody falls through the cracks and that you avoid these situations where somebody's getting EMDR and then experiencing this activation. This is really interesting because I think with dissociative, like we've heard of these things in psychoanalysis, right? Like Freud would talk about defense mechanisms or repression or regression. This idea that sounds a lot like that 6-year-old coming through. And I think Freud would talk about it as if we're going back into the 6-year-old, but the way you're framing it is the 6-year-old's always there, but now is at the forefront of experience.
Yeah, exactly. So with that same example of that 6-year-old girl, the popular girl, what ends up happening is that popular girl, that popular part of her, the social part of her, that is open to new stimulus. That is, seeing the light of day and getting to interact. And so that part actually grows up. That part grows up into her adult sort of daily living system. But that 6-year-old girl, as that has been dissociated away and almost like a castle, and walls have been erected around her, what happens is that part does not get to grow up the same way, psychologically, the same way as that adult part, that popular girl part grows up. And that's where we have the disconnect, where why is that part now only stuck in 6-year-old and stuck in that time period? Because that part wasn't that part didn't get time oriented properly. That part didn't grow with the client as the client got new experiences. Because of the dissociation, that part was not shown any new experiences or not exposed to any of the new experiences, and that's how that separation happens.
Right, because when they're the 6-year-old's coming through, it's not the popular side of the 6-year-old. That side is probably showing up in adulthood as somebody who's, however that popularity may have progressed throughout their life, whether they're successful, they have a big family or whatever it is, they're confident, but you're seeing the dissociative part sort of show up and ask for attention, perhaps.
Attention and like, child parts typically want to be unburdened. They are carrying this heavy burden of the difficult feelings, feeling alone, feeling abused. They want to basically be unburdened. And then there's also something called perpetrator parts, perpetrator imitating parts, or perpetrator introject parts. Especially when there's significant abuse, you can have a part within the client which is sort of a replica of, say, the person that abused them, right? And they are keeping sort of that in dynamic running internally. So that 6-year-old child part now this client has a dad introject, say. The dad is dad from age 6, and that dad part is continuing to like sort of abuse the child part and kind of keeping that inner dynamic alive. And so in this kind of work, in dissociative work, we also need to work on the introject parts. We need to kind of take the bite off the introject parts and to kind of like make them less harmful to the system.
It's interesting. Like I think sometimes it's interesting, family systems, very interesting kind of therapy, because we do internalize some of these different parts that I think ultimately serve, or at least part of it is that they serve as protective mechanisms. Because if I think the subconscious ideas, if we internalize our abuser, we can perhaps prevent the abuse because we're anticipating what the abuser might want or what they might be planning. And so then we can step out of the way by having our own internal abuser sort of keep us in check. There's this idea with the inner critic, we can avoid rejection and humiliation if we're criticizing ourselves. So we no longer act out in a way that may result in that rejection, humiliation. But then the end result is that we're torturing ourselves as we go through life. And a lot of that protection, quote unquote, is not needed anymore, or was never correct.
And this is exactly how we work with these kind of protector parts. Is we first like to show the, say, the adult part, the apparently normal part of the adult part. We like to first we work on showing that this part is not actually dad. This part is not actually like this evil devil critic part or anything like that. That this part is actually has been trying to protect you, has been, as you said, adapting to the perpetrator's needs and desires so as to reduce punishment, so as to survive, right? And so we try to elicit positive feelings by the adult self towards these kind of perpetrator parts and critical parts. And once that happens, then what we can help this part realize that whatever they are doing, I know part that you want to protect, but whatever you're doing is actually not helping. It's actually having the opposite effect. And so what we are essentially doing is, because this introject part is actually part of the emotional brain to some extent. It's like an old pattern. We are basically time orienting the part to present time, that, what you did when I was 6 years old was great and helpful, but now at age 34, you don't really need to do that. You don't need to be so extreme anymore. And what we are also doing is, back then, there was no adult self. It was just that the apparently normal part who was still a 6 year old. And that part, the popular girl, for example, she also didn't have much choice, agency, ability to take care of herself. And so, yes, perpetrator part, you were needed then. But now that girl has become a 30 something old woman, and she can take care of herself. Dad is no longer in the picture. Um, she has agency, she has choice. So we also show adult competence to that perpetrator part. And then we start seeing that the part starts to relax, starts to be like, oh, okay, yeah, I don't need to do this anymore. And that's what reduces activation as well. That the client is suddenly being like, okay, I don't have this inner critic hammering at me all day long. And that also then reduces symptoms significantly.
Mm. It's interesting. We're all of these moving parts inside, and so essentially, then you're bringing the complex system, all of the parts acknowledged and understood a little bit, into the EMDR experience to then start reprocessing memories.
Yeah.
Can you talk about complex trauma? So you mentioned earlier on about, well, you didn't say it this way, but little T traumas, where it doesn't have to be the big traumatic events that we think about. It could be the sitting in front of, your grade 4 class being humiliated, and it's not always these big things, because a lot of people may think, well, I didn't have it so bad. I don't remember any major issues in my family of abuse or anything like that, but that could still be contributing to depression, anxiety, or other mental health conditions.
Yeah.
Tell us a bit about that, and
Yeah.
complex trauma and how that might show up.
Yeah. So so typically it's called big T trauma, little T trauma, small T traumas. I typically don't like that way of, because that kind of minimizes, literally minimizes the T, right? And that's not really accurate. So yeah, the definition is, big T trauma is traumatic events that endanger our life and bodily integrity, and small T traumas are events that are more in ordinary nature, that exceed our capacity to cope. Okay, so those are the official definitions. Uh, but small t, what ends up happening, how I like to look at it is, big T is basically high intensity and shorter duration, while small t is lower intensity, longer duration. And so the effects of those two types of trauma can be kind of different. Unless, of course, you have big T happening longer duration. So, for example, if you have constant sexual abuse happening for years and years, that's a different matter. That's like big T happening. And so that's going to cause a lot more damage to the psyche. But if you're typically keeping it as big T being high intensity, short duration, what we see is typically that can often cause what we call simple PTSD. Nothing simple about it, but how we look at it is, we look at it as episodic trauma. So it's like one event there, one event here, one event there. Episodic, discrete trauma. Versus with small t, you can have, that's where we call it complex trauma, because if, for example, a person is being abused, or, for example, a good example is a pretty nasty divorce. Okay, so you're a person whose parents divorced when they were like, and he was like 5 years old, and it was a not a amicable divorce, nasty divorce, lots of like custody battles and here and there, parents being mean to each other, all of that, and this child not getting the help they need. right? That can now bring in loneliness, abandonment, all of that stuff, right? So what we are seeing of that is that yes, the divorce memory, and often, as you know, divorces don't just happen in a point in time. It's like often a big long process. So from a memory reprocessing point of view, it might be hard to now go to big discrete memories. So if I ask this client, okay, when you think about that time, is there a big negative memory that comes up? And they're like, no, I just remember it as those were not good times, but I can't give you this one big memory with 0 to 10 of like a 7 or 8. There's nothing like that. Instead, it's a lot of this smaller abandonment and all of that isolation, abandonment, loneliness, etc., happening consistently over many years. So those need to be handled a bit differently, and they cause repercussions to be in a different manner. And this what I'm mentioning now is not like validated or anything like that. This is my own way of looking at it. So take it with a pinch of salt. Is I look at it this way, that when the discrete traumas that happen, it causes symptoms to be at a more behavioral level, versus when small t traumas happen over longer periods of time, it causes symptoms more at a personality level, where the difference being being someone having anxiety attacks versus a person having an anxious personality. See the difference, right? Like anxious personality, I'm anxious all the time, versus someone who's having anxiety attacks. The behavioral versus personality level defenses. And so they need to be treated a bit differently. And in EMDR, there's this, again, this is one of those what we call non-standard protocols. There's something called attachment-focused EMDR, where we look at healing some of this stuff, where we're not trying to focus on individual big memories, but we're trying to bring in um, adaptive resources. So imagining now that, okay, imagining like an ideal parents. Imagine as the ideal mom and dad taking care of you through your years. So you're filling in some of the gaps. Because another thing that happens, important to know, and this is where sometimes someone can be like, I did EMDR and it didn't work, or yeah, I did memories but didn't help as much, is we can look at trauma as trauma of commission and trauma of omission. So trauma of commission is when someone is actively doing something negative to you, right? So in that case, for example, the girl getting beaten up by dad. So dad beating that girl is the trauma of commission. But often, and the typical therapists often want to focus on that. Let's go to the memory of the beatings and all that. But often what gets overlooked is the trauma of omission. So if the dad was beating the girl and no one was coming to protect her, what was it that should have happened that didn't happen? What did she miss in that experience? So she missed having a great relationship with dad. She missed having a good male role model. She missed having anyone to take care of her while she's having those big emotions. She's having to deal with the big emotions alone in her own room, right? And so those become the trauma omission, and we need ways to handle and work with that, because if we don't, then we are just desensitizing the memory, but we are not filling in the gaps. We are not filling in the holes that have now been left in her emotional body, you can say. And we need to fill in some of those gaps.
It's really interesting because I feel like, I mean, is it possible that somebody may be suffering from a series of traumas of omission without any necessarily large traumas of commission? So, I mean, lots of people will say, in my family, we just never talked about our emotions, or, I never received support, or maybe my dad was never around, and so I never had a sort of a masculine role model, a protector in my life. And it's difficult because the way EMDR works seems to be pulling up a specific memory, but it's hard you can't find a specific memory if it just was never there. And often we don't even, it maybe takes us decades to even identify what we didn't get, because we just assumed that it didn't exist,
And that kind of therapy is harder. That kind of therapy, and this is something when I do my 30-minute free consult initially for the client, this is something where I would explain that to them, to be like, okay, I asked them initially, what are you coming in for? And, if you can, without opening up old memories, if you just tell me, broadly speaking, did you have trauma in your childhood? And if they say that, no, dad wasn't there, but nothing big, then I would tell them that, um, this process is going to be a bit different. It's not going to be as cut and dry. It's not going to be just go to this memory, clean it up. And that's why it's complex trauma, right? Complex trauma means that it's complex. It's not that cut and dry.
Mm-hmm. It's really, really interesting. And it's essentially, it's like, but then even if it's a series of the smaller, like let's call them again, the smaller T traumas,
Yeah.
it's kind of like bubble wrap. Like it's hard to identify one significant memory that's at the source of all of these beliefs and physical symptoms and whatever it is that, however the trauma is showing up. If it's these little persistent occurrences that happen based out of this larger narrative, it's like you're kind of whack-a-moling them almost, no?
Yeah. And the approach that I would typically use is instead of focusing on the memories itself, I focus on the repair aspect. So we imagine bringing in, say like an ideal parent figure or nurturing figure or protective figure. And we imagine, okay, now you brought in a nurturing figure who's like a, daycare teacher or daycare lady, for example, for your 4-year-old, 5-year-old, or for that girl, say 6-year-old, you're bringing in a, kindergarten teacher or primary teacher as a resource figure, as a nurturing figure. Now imagine what's happening with them, and you're like, oh, I'm imagining that this teacher is taking care of her, reassuring her, making her feel better. And I'm like, okay, notice how that feels in your body now. Like, oh, that feels like a sort of a calming, like my nervous system feels calmer. I feel more taken care of internally. And so we strengthen that, and now we strengthen that with bilateral stimulation. We do that with, EMDR style bilateral stimulation as a way to strengthen that repair. And so then what happens is, then when I asked her to go back to be like, okay, now when you think about that 6-year-old crying by herself, how much activation does that bring up? You're like, oh, that doesn't feel that bad anymore, because now we have brought in this internal repair, as a way to fill in the gaps. So that's the approach that I would use when we are dealing with this kind of trauma.
Which is, I think, another significant point, that as adults now, we have way more resources. And this is the idea is that when trauma becomes activated and we become, or the 6-year-old comes through, the 6-year-old has a completely different context from what the 34-year-old has, which is experience and resources and emotional regulation and a whole bunch of different things that they can call in to help process these memories and protect themselves. And to, obviously a hugely traumatic situation is very different, but I'm thinking of the grade 4 student in front of his class being humiliated. That student can activate potentially in a different way, and if that's happening in the adult world, likely we're going to respond in a different way as well.
Exactly. And for my more dissociative clients, when we are doing this adult competency, like bringing in this thing, one thing that I like to do, and that typically helps quite a bit, is I ask the client to bring in their driver's license if they have one, and a credit card. And I activate the child part, and I ask them to be like, can the child part look through your adult's eyes and look down at her name on that driver's license, on that credit card, and run your fingers on the, her raised name on the credit card, right? Run your fingers on that. Just really feel that, this is who you are right now. So when there's more dissociation and the child part is activated, there can be very interesting phenomena that can happen. I can ask a client, if the dissociation is strong, I can ask them to be like, when you look at your hand right now, is this your hand? They can say, this is not my hand, right? This is not my hand. It looks like an older person's hand. And so to help that part realize, no, that this is also your hand. This is not, you're a 5-year-old, and yes, it doesn't look like the hand of a 5-year-old, but this is also your hand. And as that starts to happen, it's realization, that big realization happens. It can be very confusing for the child part initially, but over time that can be very, very stabilizing, very like calming. The child part suddenly goes like, oh wow, I have someone now to take care of me.
Once again, pulling in the room in the present moment. This is really cool. Is there anything else you want to talk about? I want to also talk about the projects that you're up to with your therapy, your artistic resources that you sell.
This is something that started in, when did I start? March 2019. Before that, for the last 6 months before that, I'd been kind of drawing. I used to draw a lot as a child. And then, adulting happened and I stopped. And so I started drawing again in 2018, and one thing led to another. I started then drawing, difficult psychotherapy concepts into like one pager artwork that therapists can use to educate their clients. Because I have a big focus on psychoeducation in my work anyway, and I was using one such sort of a visual aid tool by Janina Fisher. And even though that's great, I was like, oh, it's like a black and white thing. I was like, oh, I wish there was some more color. I wish there was something this, something that. So I was like, okay, well, if I'm drawing myself, why not make something for my own self? And so initially I started drawing things that I was like, if I had to explain this to a client, what's the imagery that I would use? So I would draw that. And then I started sharing that on Instagram. And then some therapists like, I would buy that. And I created these visual aid flip books. So at the moment now I have 3 visual aid flip books. One for trauma and EMDR, which has 6 drawings specific to EMDR. One is on general trauma therapy, so different concepts, intergenerational trauma, window of tolerance, polyvagal theory, lots of different things in one book of 18 drawings. And my latest book has been on attachment, trauma, and dissociation. So 3 books. And my latest little mini project now is because I've had some therapists go like, I haven't been seeing my clients in person due to COVID, but I would like to send them something. I would like to send them like a greeting card or something as a way to like kind of just be like, hang in there and you're doing a great job or something like that. And so I've decided to create a set of 10 more inspirational artwork and sell it as a set of 10 5x7, 5-inch by 7-inch kind of greeting card like things that can be used by a therapist to even decorate their office or their table with a photo frame, and it has a space for a message on the back, or you can send it as a greeting card to your client.
Which is kind of cool. Like what comes to mind with that is that if you're reprocessing memories and you're leaving someone with the more balanced thought, it could be something that they write on the card to just check in with, do I still believe this? And it's a way to sort of gauge response to therapy throughout the rest of the week.
And that should be coming out in the next. So I've completed the artworks and I need to send it to my printer now, and should be giving it back to me in the next few days. So I should be releasing it on my Instagram in the next 3-4 days.
This is awesome. Yeah, and we'll provide a link to your Instagram, to your Etsy store, which is therapyillustrated.com, and also your website where people can check you out. So obviously, to work with you one-on-one would have to be somebody who lives in Ontario, but you do conduct 30-minute consults to see if you're a good fit with people.
And a 30-minute consult, apart from good fit, I also like to, use the time to educate this person that even if you're not working with me, even if you are going and finding some other therapist, it would be helpful for you to know certain things. Some of the things that we talked about in this, this episode, those are some of the things that I mentioned in a quick monologue-y way on this call.
No, this is awesome. And this is a great resource too. You can send this to people to get some more background. And there's so many things we didn't talk about. Like we didn't get into polyvagal. I mean, I'd love to talk more about dissociation because that's a whole topic. So I'd love to have you back on this new podcast.
That would be great. And you're doing and this seems like, this, as we were talking about earlier, to become like the Joe Rogan, the female Joe Rogan podcast for like, health.
We'll see. With a bit more. We can. I'm hoping to do like long, because I think after the first hour, that's where things start to get deep, and I think that's what a lot of podcasts miss is. And so there is something to be said for the long form version. But we had a good talk today, and I don't want to keep you longer because I want you to enjoy your family time and your lunchtime. But thank you so much, Ayan, for talking to me. And and we'll touch base again. We'll definitely record again if you're willing.
Thanks so much for having me, Tanya.